So welcome everyone to the Med Crash Course series. Today we've got the final Crash Course series, Cardiology Part 3, and we're also including a little bit of Vascular in here as well. And it's taught by Dr. Lakshmi. So in the top right corner, you'll see the QR code for our Med Crash Course Instagram. So please do scan and follow. And in the bottom left corner is the email for us. And if you have any questions or anything, please do email in. We go on to the next slide. So this is the QR code for the polls if you guys want to join in. So just scan in and join, and then you can answer the questions. It's completely anonymous. So I will hand over to Lakshmi.
Hi everyone. Right, so we're going to cover these topics today. I understand these are slightly minor topics as well, but the vascular ones are a bit more major. So we'll cover them, and feel free to ask questions as we go along. And it's of course going to be focused on SBA. So we'll start off with questions. I'll give you a couple of minutes, and then we'll go through content together. Cool. So first to SBA. Quickly read it out. 45-year-old man presents to A&E with fatigue and weight loss. 1 month history of reduction in exercise tolerance and shortness of breath. Father died in his 50s. Remembers having genetic tests done as a child, but can't remember what the results of these were. He drinks about 8 cans of cider a week, and on review of systems, you know that he's had some intermittent fevers over the past 2 weeks and a recent upper respiratory tract infection. He's otherwise fit and well. On examination, you hear a systolic murmur and swollen ankles. So what do you think the likely diagnosis is? I'll give you a minute or so. Okay, so the answer is C, infective endocarditis, and we'll go through why that's the case. So pathophysiology behind infective endocarditis, essentially it's to do with platelet vegetation and a bacterial infection that seeds, usually sourced from the skin, that penetrates the endocardium of the heart, and as a result leads to valvular insufficiency, which is why these patients often have a murmur, as well as systemic effects, which includes the intermittent low-grade fevers as well as emboli. Risk factors for IE, as everyone knows, can be valve disease as well as rheumatic valve disease, so that tends to be more of a global issue with rheumatic fever as opposed to an issue we see in the UK that often. Also things like hypertrophic cardiomyopathy, structural heart disease, of course people who inject drugs are at risk of IE, as well as general poor oral hygiene and diabetes mellitus as well. Always key thing to remember is if any question prefaces with a fever and a new murmur, it's IE until proven otherwise. So and the fever would be greater than a week, not just a fever for 2 to 3 days. Okay. Usual common bugs that is good to remember for exam questions are strep viridans and mutans, which used to be the most common, I think, and is from a dental source, but now I think the most common would be Staph aureus. If you're looking at the population of people who inject drugs. Staph epidermis is something you'd see if someone's got prosthetics due to biofilm formation, and your HACEC or HACEC organisms, which is the ones I've listed below there that are commonly seen. Cool. So signs of IE, which is good to remember, essentially it's a sign of the embolization of the vegetation on the valve to everywhere else in the body. So if it goes to the brain, you get a stroke in the lungs. You can also see that more commonly with a right-sided IE because the vegetation is on the tricuspid valve. You can also get it in vessels, which causes aneurysms or vasculitis, etc., etc. So the pictures on the side, I'm not going to force you guys to tell me what you think each of those signs are. Essentially, the first one on the top is Janeway lesions. And I guess a good way to think about those is that they're sort of just irregular and painless that you see on the palms of your hands. The second one is splinter hemorrhages. Again, this is due to essentially the emboli getting stuck in nail bed vasculature, which causes small hemorrhages in the nail bed. The third one, which can only be seen on fundoscopy, is Roth spots. So of course, if whenever you're examining a patient for anoscopy, for example, don't say that you're looking for Roth spots unless you mentioned fundoscopy as well. And the last one is supposed to be Osler's nodes, more because it's on the pads of your fingers and it tends to be painful. So I remember Osler's nodes, ouch, oh. So remember that's the difference between Janeway and Osler's, which can look quite similar. So investigations, you need 3 sets of blood cultures at different times and preferably from different sites as well. Other blood tests you can do include your general sort of full blood count, CRP, using these LFTs to get a baseline picture. Urinalysis or urine dip might show microscopic blood in the urine. Chest x-ray, again, they can be in pulmonary edema or show cardiomegaly, but echo is the most sensitive test to identify if someone's got IE, and preferably a TOE, but most centers can't go straight to doing a TOE unless it's a specialist cardiac center. So TOE being transesophageal. So first line tends to be transthoracic, and then you move on to transesophageal if needs be. So this is the Duke's criteria. I'm not going to go and read through all of these. You guys can use this for your revision. Good to remember that there's obviously major Duke's criteria and minor Duke's criterion for a definite diagnosis of IE. According to the criteria, you either need to have 2 of the major criteria, or 1 of the major and 3 of the minor, or all 5 of the minor criteria. Most commonly, you'll probably see 1 major and 3 minor, clinically speaking, but you can just get 2 major things, which could be the culture scoring positive for organisms that are more indicative of IE, and of course the imaging, which we discussed before. Usually starts off with a TTE, and then you can get a TOE if needs be. Cool. So management of IE is essentially just antibiotics for ages. So typically patients will need antibiotics for 4 to 6 weeks, and I think it is recommended that they get IV antibiotics. It's not something where you can switch them to oral and send them home, unfortunately. These patients often end up having very long stays in hospital. Sometimes they can be seen sort of in an outpatient hospital environment where they come in for an IV antibiotic regime. But essentially with management, it's summarized in this table. What's really important to know is whether the valve in which is suspicious or has signs of IE, whether it's a native valve, basically the valve you were born with, or whether it's a prosthetic valve, so it's been replaced at some point in the patient's lifetime, in which case the choice of agents varies, and of course what bug you grow as well will tailor your treatment. But generally speaking, I think the good ones to remember are the top 2 in the green, which is remember that if this is a patient and they've not mentioned any kind of prosthetic valve implant, then your first line treatment would generally be a MOX plus or minus gentamicin. But obviously check trust guidelines when you start working. Cool. So next one. You get called to cardiac arrest for a 62-year-old man and observe that the initial rhythm check shows pulseless electrical activity. What do you think the most single appropriate step in the management of this patient would be? So we've got lots of drug choices: amiodarone, adrenaline, calcium gluconate, atropine, and adenosine. For interest of time, I will just go through the answers with you guys. So the answer is adrenaline. 1 milligram IV. We'll go through the pathways in a second. The next SPA, the next SPA is after you've given this patient adrenaline, patient's found to be in pulseless VT on the next rhythm check in 2 minutes. So you have 3 further cycles of CPR where you've given shocks. What is the next appropriate step in the management of this patient now? So you've given adrenaline, they've had 3 cycles of CPR with shocks. What sort of drugs would you want on board at this point? Again, this is all based on the algorithm, which we'll go through in a bit. Brilliant. So the answer is amiodarone, 300 milligrams. So cardiorespiratory arrest. I feel like this was a topic I wasn't as comfortable with in finals, just because I've seen a couple of arrest situations, but it's usually very chaotic. It's quite hard to deliver teaching during an arrest situation unless you're very well staffed and you can just stand back and observe. We all know the definition, essentially just sudden circulatory failure due to potentially a loss in systolic function, often due to a thrombus, so MI, or it can be due to electrolyte abnormalities precipitating a malignant rhythm. The survival rate is surprisingly quite low, so 15% in a hospital setting and less than 10% out of a hospital setting, which I don't know, in my head I would have thought it would have been slightly higher in hospital. And ROSC, which is return of spontaneous circulation after CPR, is achieved in approximately 30% of cases. So your two pathways that you need to remember for cardiorespiratory arrest, or is good to know where to look for information regarding this, is your shockable and then your non-shockable pathways, which is shockable being your VF-VTs and non-shockable being your pulse electrical activity and asystole. Remember your 4 H's and T's. These are the reversible underlying causes that you try to work through as you go through cardiac arrest call, and try to exclude these causes that may have precipitated the arrest. So hypo or hyperkalemia, low temperature hypothermia, hypoxia or hypovolemia. The first and the last ones are probably, and hypoxia, sorry, are more common. Hypothermia, generally speaking, isn't common, but would be quite an obvious sign because they would come in with a low temperature. Thrombus, which can be either PE or an MI, toxins, during medications that they may have had, attention pneumothorax, again, usually due to trauma, but could also be just a spontaneous pneumothorax, as well as tamponade as the 4 T's. So I've put the 2 algorithms up here that I think are most important to remember. I'm not covering all of them because that would be beyond the remit of the session, and it's good to go look on the Artery UK website for the adult bradycardia algorithm as well. But generally speaking, like we said, so you find a patient unresponsive, not breathing normally, so you start CPR, call for help, obviously, and you do your rhythm checks. And when you get your rhythm, if it shows or it looks like it's in a broad complex VT or VF, you would administer a shock and then continue CPR. And you would do this for 3 cycles, providing the rhythm check after every check is showing VT or pulseless VT. So always check for the pulse centrally and VF. After 3 cycles is when you start, 3 cycles where you've administered shocks is when you start giving amiodarone as well. And during this time, you're also trying to identify, going through your 4 H's and 4 T's, trying to work out what may have precipitated this arrest. Adrenaline is given every 3 to 5 minutes during your arrest. So generally, a set of CPR compressions and then rhythm check will take 2 minutes. So you'll often have a scribe who'll be prompting for when things need to be given, or also having a leader who'll be keeping that in mind as well. If you go down the non-shockable pathway, it's slightly different. So this is when they've got electrical activity that may even look normal, but there is no central pulse palpable. So pulseless electrical activity, or it's just, flatline asystole. So in those cases, you just continue with CPR. Shocks aren't visible, and you do regular rhythm checks. Of course, once after you've done CPR for 3 to 5 minutes, you can also consider adrenaline. But in terms of an MCQ question, I think the things that you will have to be aware of for your finals exam is just you might be given a rhythm strip and be asked what would the next management plan be, in which case you need to know whether this is shockable or non-shockable and how much CPR they've already had, because that will affect which drugs you want on board. So adult tachycardia. Again, this one's a very important algorithm to remember. I'm not going to go through the whole thing in detail. Just remember, if patients are complaining of chest pain, are overtly in pulmonary edema, have collapse, so syncope, in some kind of shock, then you immediately go on to shocking them. You don't go through, assessing whether the QRS is complex and narrow, etc. And that's synchronized DC shocks. If, however, they haven't got any symptoms or signs of instability, then you can do basically your rhythm check, and you check whether, once you've established this as tachycardia, whether the QRS is broad or narrow. Generally speaking, with broad complex tachycardias, our first line, of course, will be amiodarone, which is 300 milligrams IV over 10 minutes, usually, preferably through a large vein because it can be irritable. And another thing to remember is sometimes people with a background of atrial fibrillation and bundle branch block may present as a broad complex tachycardia, but you'd usually get senior support in those situations. Another broad complex tachycardia that you need to be aware of is torsade de pointes. So that's where you've got the twisting, sort of QR, or not even QRS, twisting motion seen on ECG. And for that, the treatment is IV magnesium, which you'd have to give over 10 minutes. So that's broad complex. And then narrow complex tachycardias generally are more common and what you would see in clinical practice more often, and you can attempt vagal maneuvers. It's quite difficult to actually do a vagal maneuver. You have to press onto someone's neck as hard as if though you were squeezing on a tennis ball, so it can be quite uncomfortable for a patient to be able to get to the carotid sinus. If that's ineffective, which it most often is, you would give adenosine, and you can give multiple boluses of adenosine and see if your patient reverts back to a normal sinus rhythm. Okay, always remember in your asthma patients, we don't prefer adenosine, and you would give verapamil. Okay, and yeah, if ineffective, you will inevitably then go on to shocks. So that's the cardio algorithm. So next question, 24-year-old male presents to A&E with a stab wound to the chest. On examination, oh, they've changed gender, surprising. The heart sounds are quiet and JVP rises on inspiration. Blood pressure is 75/40, heart rate 120, and temperature is 37. And they also appear to be a bit confused. So what do you think the next appropriate management would be? So there's key signs in these questions that would guide your answer. More appropriately, it's the stab wound and the examination findings of a quiet heart sound and JVP rising on inspiration. So the answer is emergency pericardiocentesis. This is a case of cardiac tamponade. Essentially, tamponade is when the heart gets compressed because the pericardial sac gets filled with either fluid, which can be blood, or even clots or gas. And this essentially sort of increases the pressure on the heart, which means it can't relax and fill the ventricles properly, and you end up getting quite a poor cardiac output. It can be classified in multiple ways, so the distribution of the fluid in the pericardial sac, or the size of the pericardial effusion, for example, or whether it came at the onset, because cardiac tamponade, contrary to what you may think, because in my head I always think that's quite an acute scenario, can actually be subacute or even chronic, occurring over 3 months or so. You can also classify according to the content. So transudate would tend to be fluid, so hydropericardium. Exudate could be a sign of infection potentially, which is pyopericardium, and then obviously hemopericardium, more commonly seen with trauma, which is blood in the pericardium. Differentials I've listed there below, and these echoes essentially just show, I'm sorry I don't have a pointer, but I think you can all appreciate that there is an enhancing fluid area around the heart, especially on the bottom one. Yeah. So signs of cardiac tamponade, your classic Beck's triad, which is raised JVP, muffled heart sounds, and hypotensive. You'll notice that they often don't respond to your fluid boluses when you're trying to resuscitate them. And because of the poor sort of ventricular filling, they try to compensate for the reduction in cardiac output by increasing their heart rate, so patients are often tachycardic. Pericardial rub is another common sign that you can see, and which other one I think is important to discuss. Again, because more signs, if you're good at appreciating a JVP, it's often raised, which is uncommon in constrictive pericarditis. So pointing more towards a restrictive picture. Investigations you can do is a chest x-ray, which shows a globular heart, also sometimes known as a water bottle sign. ECG will show low voltage QRS complexes, which makes sense because obviously the heart is unable to relax and pump as it normally would, so you get low voltage. Echo would show obviously fluid surrounding the heart, and your treatment would be try and treat the underlying cause. So if someone's obviously had a stab wound, then you need to resolve that and stop the bleeding and try and fix the issue that's caused the tamponade. And pericardiocentesis is the most acute management for these patients, where you essentially pop a needle in and drain the fluid out from the pericardium. Right, next question. 60-year-old man has a long history of hypertension and angina. 4 weeks ago was started on an ACE inhibitor by his GP. His creatinines rise from 100 to 350, and renal ultrasound shows that one kidney is larger than the other. So, likely diagnosis. Okay, so it's renal artery stenosis. We're covering renal vascular disease as part of this course. So renal artery stenosis is essentially a narrowing of the renal artery lumen. This leads to reduced blood flow to the kidneys, and therefore they excrete more renin in the juxtaglomerular apparatus. This leads to a rise in angiotensin II, and aldosterone, which causes vasoconstriction, and then also increased absorption of sodium, therefore water as well, which increases your circulating volume, and you get a higher blood pressure because of this constriction, as well as an increase in your volume. Causes of renal artery stenosis is usually atherosclerosis is the big risk factor. You can also get commonly see it in exam questions in sort of females with fibromuscular dysplasia as a background. Complications, of course, is hypertension that's refractory to treatment, renal atrophy and renal fibrosis as well. And going through diagnosis and management. Diagnosis is usually with Doppler ultrasound of the renal arteries, and the most definitive, I guess, gold standard would be to do magnetic renal angiogram, so MRA. Treatment is actually can be. So this is slightly confusing, and we've actually had patients in hospital with this, but you can give ACE inhibitors to people with renal artery stenosis, but you wouldn't give it. It's a contraindication in people with bilateral renal artery stenosis. So obviously you need to image them before you start giving out an ACE inhibitor in these patients. You can go on to, apart from your medical management of hypertension, you can consider stenting, which is usually seen with people with atherosclerotic disease, and balloon angioplasty seen in the fibromuscular dysplasia patients as well. If they've also noted to have a AAA, often these patients can then go for a surgical reconstruction where they'll get the renal artery remodeled as well as the AAA remodeled too. Right, next question. So 88-year-old female has some abdo pain, discharged 4 weeks ago after having an aortobifemoral bypass graft. She's got diffuse tenderness on her abdomen and absent bowel sounds. X-rays unremarkable, HB is fine, white cell count is raised, urea is raised, creatinine is raised, CRP is also raised, and her ABG shows that she's acidemic. CO2 is 30 and PCO2 is 4.6. She's got a lactate of 4.5, which is concerning. So what do you think your most likely diagnosis is? I'll give you a couple of seconds. Right, so the pertinent part of this question was in the history that she's had aortobifemoral bypass graft, and this is essentially a classical picture of mesenteric ischemia. So mesenteric ischemia is when you get insufficient blood supply to your small intestines, and as a result you can get pain. It's almost described as gut angina sometimes, and it's good to remember anatomy, I guess. So the blood supply for your small bowel is your superior mesenteric artery. Classical signs are they often have abdo pain after a meal. So again, this idea of gut angina, nausea and vomiting, sometimes even PR bleeding or guarding. I've gone through some causes there. This flowchart basically describes how you can classify mesenteric ischemia. So of course you have both your venous and arterial blood supply, so that is the first differentiator between your mesenteric ischemia. And with venous thrombosis, it's usually just due to the fact that you've got high risk factors for hypercoagulation. So that can be either malignancy, potentially even a tumor compressing on the venous system, or if you've got risk factors like taking the combined oral contraceptive pill or having IPD, etc. In the arterial cases, you then look at whether this is occlusive or non-occlusive. If it's non-occlusive, then this may just be due to low blood pressure and vasospasming of the arterial of the arteries rather, which can be treated with increasing your cardiac output and giving vasodilators like piperine or mebeverin. Occlusive, however, can either be due to an embolism or a thrombus. So if it's embolic, that's, for example, a sign of IE even, or an MI or an AF where you've got a cryptogenic clot, and your treatment would be to remove that embolus, which is an embolectomy. If it's thrombotic, for example, due to having a history of vasculitis, or you've had trauma to your bowel, then the treatment would be bypass graft. And complications with mesenteric ischemia most commonly will be ileus. So yeah. Moving on, 68-year-old male collapses when rising from a chair and is seen in A&E. 45 minutes later, he's conscious, but he's got reduced power in his left arm and left leg. That's the power scores respectively. And there's slurring of his speech. Background is COPD and hypertension, smokes 10 cigarettes a day, has a bilateral scattered wheeze, and carotid bruit on auscultation. So what do you think the most appropriate initial radiological investigation would be for this patient? It's quite a tricky question. So this question leans into the examination finding of carotid bruits, and for all intents and purposes, a sign of having a TIA or a stroke. So CT head would be your first radiological investigation, although these other investigations are also considered to be good later on. Your initial choice would be a CT head in this patient because you want to rule out a bleed. So carotid artery stenosis. This refers to essentially buildup of atherosclerotic plaque in either the common carotid artery or your internal carotid artery, usually, which leads to stenosis and eventually occlusion. Signs are cervical bruits. You can also get focal neurological deficits, so that's what was in the question before, the TIA. You can also get CRAO, which is an ophthalmological condition, central retinal artery occlusion, and this is just due to the plaque essentially rupturing and going up along the carotid artery to block your central retinal artery. Investigation for this would be a duplex ultrasound scan or a CT of the CT angiogram, of the head and neck, so that you can visualize the vessels. Treatment would be anticoagulation statin and also your general sort of vascular management of patients, so managing their blood pressure and their diabetes if they have diabetes. Carotid endarterectomy, which is where you remove the plaque, is often done if patients present with acute stroke or TIA and have significant stenosis above 50%. You often find, surprisingly, that patients who tend to be stable are the patients who have total occlusion. If they present to you and are generally speaking to you well, total occlusion patients have often developed sort of significant collateral systems whereby they bypass this total occlusion, and if they are well with it, sometimes surgeons might not even operate on them just because, well, the vessel's totally occluded, but they've compensated for it well themselves, so there's no need to go in and take it out, if that makes sense. But yes, this is the degrees of stenosis and percentages of reduction in diameter, which might be an exam question, I'm not too sure. Right, moving on. 60-year-old female presents to ED with progressive 1-year history of shortness of breath and recent onset paroxysmal nocturnal dyspnea. Previously well, had Sydenham's chorea as a child, had 6 normal pregnancies, and on examination you can see she has plethoric cheeks, irregular small volume pulse, slightly tachycardic, blood pressure is normal, JVP is normal, tapping apex beat, and a loud heart sound 1, as well as the P2 component being accentuated, and a low-pitched apical mid-diastolic murmur, which you'd grade as 2 out of 4. So I've tracked on a lot of signs here. I think it's pretty obvious. This is a sign of mitral stenosis and rheumatic because of the Sydenham's chorea as a child. So we'll go through that in a bit. Next question, 65-year-old female again. Aortic, has mechanical aortic valve replacement and has had coronary PCI 3 days ago. Being treated with dalteparin. She is taking aspirin long term. What is the most appropriate long term management for this patient? Is it to have apixaban, copy, continue the dalteparin, rivaroxaban, or warfarin? This is a bit of a tough question. The answer is warfarin, of course, because for metallic valve replacement, DOACs still aren't licensed, so we would be giving her warfarin to cover for that. So last question in this, I think. 54-year-old female presents with palpitations. You notice that they have a late systolic murmur and a mid systolic click. ECG shows T-wave inversions inferiorly. Okay, so what do you think? The pathology is, and well done those who got it. It's mitral valve prolapse. Key identifying factor in this question is the mid systolic click. And 98-year-old man presents with all of these eponymous signs that sound very vague. What do you think the most likely valve abnormality is? So it's aortic regurgitation. Always remember, generally speaking, exam questions, if there are eponymous signs for a valve lesion, it tends to be aortic regurg. I've actually given you the more obscure signs on this. So de Rosier's, Rosenbach's, Gerhard's, and Mueller's. You guys can go look that up. Got a summary of valve defects on this table. I'm not going to go through all of the valve defects in detail. Good things to think about with mitral stenosis is remembering, obviously, if it's rheumatic or non-rheumatic. And essentially management for mitral stenosis would be controlling someone's AF, because obviously mitral stenosis leads to dilation of the left atrium, and then that messes up your electrical activity, so you end up getting AF. And also considering surgical repair of the valve. Similarly is the case with mitral regurgitation as well. The examination findings for both on your auscultation will vary, however. So obviously mitral regurg being pansystolic and mitral stenosis being a mid-systolic rumbling murmur. Aortic stenosis, most common sort of congenital abnormality that we see in patients or who have a bicuspid aortic valve, often present with this triad of, sometimes referred to as SAD, so syncope, angina, and decompensated heart failure. And management of these patients essentially is getting a TAVI. You would see that even patients who are quite old and have a lot of comorbidities still end up getting transcatheter aortic valve implantation, because the benefit, symptomatic benefit of this procedure is so significant that it's considered to be done even in people with significant comorbidities. Aortic regurg, however, will require aortic valve surgery, and that is open heart surgery and will require a patient to have a level of good performance status preoperatively. So I hope you find that table useful. Also put in signs for both those valve abnormalities in. So next question, 72-year-old male, found to have a 4.5 centimeter infrarenal aneurysm on routine screening with abdo ultrasound. Previously remained stable, so it was 4.4 centimeters. What follow-up is most appropriate for this patient? Sorry, the 4.4 centimeter was on a ultrasound a year ago, so that might help you. So do they no longer need an ultrasound, 3 monthly, 1 yearly, 3-month CT abdo, or elective endovascular aneurysm repair? We'll go through it. So it's 3 monthly ultrasound, and we'll go through why. So AAA is defined by having a diameter of your abdominal aorta being greater than 3 centimeters, and it's very common in men over the age of 65, which is why we have a national screening program for it. Risk factors I've written on the slides there. Often people are asymptomatic, that is the most common symptom of AAA, but they can also have abdominal pain, back pain, or even loin pain. So think loin pain in the elderly should always trigger alarm bells about AAA, or you want to exclude AAA. They can also have limb ischemia, which is a sign of complication of AAA, or a pulsatile mass in their abdomen. Investigations are abdo ultrasound as well as a CT abdomen if you're planning for intervention. And management conservatively initially is to encourage weight loss and to control risk factors, so hyperlipidemia and high blood pressure. So in the screening program, people with aneurysms that measure from 3 to 4.4 centimeters get annual ultrasounds. And once you've hit 4.5 centimeters, which was the case in our question, they then go on to having 3 monthly ultrasound scans. The diagnostics, the criteria for getting elective open surgical repair, which is OSR, or endovascular aneurysm repair, I've listed below. Essentially, it's when they've hit a certain number in diameter, or the fact that the aneurysm is growing faster than we would like. And risks of AAA is essentially AAA rupture. Management is, this is an emergency, so you'd go with an A to E management, fluid resuscitate these patients and transfuse blood when you can get it, because obviously they are leaking blood. You would consider emergency EVAR if your centre can offer it in males and females over the age of 70. Generally in younger patients you would go for open surgical repair, so less than 70. And the picture on the side, so you can see on the CT, is essentially a ruptured aneurysm where blood is filling into a false lumen there. Okay, brilliant. Next one is 82-year-old female attends GP complaining of legs that feel heavy and painful after she's been standing for a while, and you know that she has a background of diabetes and heart failure. So you've observed her leg, and this is what you can see. What do you think the most likely diagnosis is? So it's peripheral arterial disease, and we'll go through why that's the case. Sorry, this slide is very text heavy. Essentially, the pathophys behind PAD is that there's obstruction in your arterial system, which leads to reduced oxygenation of the limbs, and so you get claudication, which is almost like leg angina. And this is because the obstruction worsens when you're exerting yourself. And if you start to get rest pain, which is progression of your disease, so that's when you're getting pain even when you're not exerting yourself, this is defined as critical limb ischemia and often has signs of skin ulceration, which is what we saw on the previous slide. And this, if untreated, can lead to gangrenous necrosis and eventually will require an amputation of the necrotic limb. So most patients are asymptomatic with PAD until severe disease develops. Signs and symptoms, so as we explained, the intermittent claudication, which is often relieved by rest, and then it progresses to rest pain, and then you can also see skin changes as well. So chronic limb ischemia, the most common type of PAD, is often due to atherosclerosis. I've listed the risk factors there, and management of these patients largely involves controlling their cholesterol levels and their blood pressure and diabetes, and encouraging weight loss. Acute limb ischemia is often due to an embolus, so your risk factors are hypercoagulability, stasis. You're all familiar with Virchow's triad. And functional limb ischemia, this is often due to transient vasospasm in the arterial system, and particular drugs can predispose to this. One other thing that might be an MCQ is Berger's disease, which is a rare form of PAD. Commonly, risk factors will be smokers and very young patients, so 25 to 40 years old, who don't have atherosclerotic inflammation or thrombosis of their veins and arteries. So we've gone through PAD. Chronic limb ischemia, again, can affect both the upper limb and lower limb, and I've given you sort of common sites that this can occur in and signs that you can see. Remember your 6 Ps, so pain, pallor, paresthesia, perishingly cold or poikilothermia, pulselessness and paralysis. If they are complaining of upper limb pain, tends to be generally women, around middle-aged women. Think of Takayasu's arteritis, which is a form of large vessel vasculitis. And with lower limb pain, again, we've gone through symptoms of claudication. Most commonly is unilateral, but you can sometimes have bilateral lower limb ischemia. And signs that you look out for is hair loss on the leg, change in colour of skin, ulcers, thick toenails or thick, very shiny skin. Again, the 6 Ps. Another sort of eponymous syndrome that you might get in a question is if someone's presenting with claudication, absent femoral pulse and male impotence. This is a sign of Leriche's syndrome, where it's caused due to saddle aortoiliac obstruction. Okay, so investigations, as you all know, and you may get in OSCEs as well, you would do an ABPI, where essentially you're measuring the systolic pressures in both the ankle and the arm and comparing them. And normal ABPI is 1 to 1.2. In peripheral arterial disease, this is actually lowered, so it can go to 0.5 to 0.9, and it's defined as critical limb ischemia if it goes below 0.5, or if your ankle systolic pressure is less than 50 millimeters of mercury. Other investigations you can do is a duplex ultrasound scan, CT and MRI, particularly if you're thinking about intervention, and you can classify according to Fontaine's criteria, which I've listed below. So, management of PAD. So prophylactically, again, reduce risk factors. It's all about risk factor management. So quit smoking, treat the blood pressure, the high cholesterol, and the diabetes. And you would also prescribe these patients an antiplatelet. So that can be clopidogrel or aspirin. Conservative management is also supervised exercise programs, where they go for 2 hours a week for 3 months, and that's to improve blood supply whilst also managing their pain, because obviously these patients will to an extent suffer with claudication. And medical surgical treatment for PAD, things to be aware of are some medications such as naftafural oxalate. I don't think I said that right, but it's something that it's actually a bit of a rare drug, but I think is used in GP as well, and can provide sort of symptomatic benefit to patients who don't want to undergo surgery or who aren't fit for surgery. And patients on these drugs need to be reviewed at least every 3 to 6 months. You can have percutaneous angioplasty for disease where it particularly just affects, say, one significant arterial vessel, and the balloon essentially widens the affected segment. You can also go for bypass grafting, and last stage surgical intervention would be amputation, and this would be considered in people who just have intractable pain or present with gangrene or neck fash. So yeah, I think this might be the last question. 55-year-old man presents to A&E with severe leg pain. He's had it for multiple months, but now that it's become unbearable, and he was sent back from work because he couldn't work. He has a history of angina, diabetes, and gallstone disease, smokes 20 cigarettes a day, drinks about 10 to 12 units a week, has a high BMI, so risk factor profile developing there. And do you notice this on examination? What do you think the most appropriate action is? So you can see on his right foot, there's a patch of white pale skin. So management for this patient would be to refer him for urgent assessment by a vascular surgeon. This is essentially a sign of acute limb ischemia. I'm not going to go through all of this again because we've covered the 6 Ps. But yes, this is a vascular emergency, hence we'll need to get them referred to vascular surgeons, where they may need surgery to restore the blood supply within 4 to 6 hours. So remember, that's the timescale that this needs to be considered in for these patients. And especially given the fact he has a history of AF, you'd be thinking this could be an embolus cause. So, investigation and management of acute limb ischemia, you would need urgent CT angiography. That's Rutherford's classification that I've put up there on that table, as well as on the bullet points. And essentially, you have a viable leg, you can have a threatened leg, and then you can have a irreversible leg where you may need amputation or, yeah, essentially that's it, really. Management depends on which class your leg or disease is currently presenting at, and in all these patients we still give antiplatelets, so aspirin or clopidogrel, after the event to prevent recurrence. So obviously before someone goes into theatre, you wouldn't start aspirin or clopi just because of the bleeding risk. But yes, also be aware that these patients can suffer from reperfusion injury. So once you've opened up the blockage, and you get a lot of reactive oxygen species, or even compartment syndrome, where it's pain that's uncontrolled with analgesia. So, okay, maybe this is the last question. 70-year-old woman comes to GP with just for a routine checkup, no complaints, past medical history, is nothing relevant. Physical examination shows several varicosities on the popliteal fossa, which is intended to palpation, but you can note little bullae. What do you think the most possible complications likely to occur from this condition? So you've got all these options there that sound quite viable. The main thing with this presentation is rupture and bleeding. So superficial varicose veins can cause these thin bullae, which can rupture and bleed from even minor trauma, and is a common complication. Okay, skin changes do occur, but with the pigmentation and the eczema, but the last three don't tend to come with varicose veins. They're more sort of signs of peripheral venous disease. So venous insufficiency and varicose veins, it's basically described as functional changes in lower extremities due to persistently raised venous pressures in the venous system, and this results in venous reflux and valvular incompetence. So leakage at your venous valves will lead to retrograde flow of blood, and because your veins can tolerate high pressures, they're not like your arteries, which are muscular. What happens is your deep veins will continue to allow this retrograde flow, but your superficial veins can't, and they end up getting dilated and tortuous, which is what we see with the varicosity. Essentially, it only takes one valve in your venous system to result in a varix. So risk factors are pregnancy, obstruction, so DVTs, for example, extravascular tumors pressing onto your venous system, obesity, of course, and age is commonly seen in elderly people. And signs can include itching, discomfort, sort of restless leg, and edema, or even burning sensation down the leg. It's a very common disease, and 1 to 2% of the population of people who do have varicose veins have severe disease with ulceration. So this is a lovely slide with a comprehensive annotation of signs that you can see with venous insufficiency. So I don't know if the varicosities are so obvious in this picture, but you can see signs of atrophy blanche, which is the white patches, lipodermatosclerosis, where you look around the malleolar region, so basically around your ankles, for thickened skin, ulcers on the back of the calves, which are usually painless. I apologize. The skin starts to go darker, so you get hyperpigmentation, particularly around the calf, and that's just due to hemosiderin deposits, and then ankle swelling as well. So investigation in these patients would be a duplex ultrasound, which is basically a combination of both Doppler and normal ultrasound, and triplex would be where you get color flow imaging of the valves as well. And this helps to identify any obstruction or signs of like where this valvular reflux that's precipitating your varicose veins may be coming from. In advanced disease, you may even consider CT or MRI. So differentials I've listed there below that you guys can read through in your own time. Management for these patients is quite conservative, so you educate them about how they can best manage the symptoms by avoiding standing for a long time, elevating their legs, losing weight, and trying to encourage regular walking, because obviously your calf muscles, when they contract, will push blood out of your venous system and improve your venous return to increase it. Graded compression stockings, which is kind of what I guess regular walks is trying to do, but without the moving. For patients with severe disease, they often get these compression stockings lifelong. And skincare is very important, as we saw in the previous slide. So regular moisturizing and referral to vascular if they start to get ulceration, severe impact on the quality of life, or bleeding or pain. Treatment I've listed below can include radiofrequency ablation, which is basically where you put a catheter into the vein and destroy the endothelium and essentially close up the vein that is incompetent. You can get endovenous ablation, which is with laser therapy, injection sclerotherapy, where they basically inject foam into multiple sites, and then you have post-op compression for at least 6 days. And a Trendelenburg procedure, which is more invasive and involves ligation of the saphenofemoral vein. and multiple revulsions. But treatment, generally speaking, is only done in people with severe impact on quality of life and who have severe pain. It can be done for cosmetic purposes, but this, of course, is not available on the NHS and would be a private treatment. Right, so that's all of our content today. Thank you for listening, and I'll hand it over back to Ash.
Thanks again, Lakshmi, for doing the session. So here's a QR code for the feedback form, so please do scan and give us your feedback, because it's always really useful to improve for next sessions. And if you're listening on YouTube, please do fill in the feedback form as well, because we do keep it open for quite a while, because we know a lot of you do watch it, watch the recordings on YouTube. But yeah, thank you.
Thanks, guys.